First speaker is our very young budding clinician scientist. Her name is Kanchan Satpute. She hails from Maharashtra and currently she's a senior fellow at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences. And she has lost a lot of experience in goniotomy in primary congenital glaucoma. She'll be discussing the techniques and all the intraoperative problems, complications that can occur during this surgery and how to prevent them. So over to you, Dr. Kanchan.
Thank you. Thank you so much, sir. I'm just sharing my screen now. Okay. Is it visible?
Yeah, we can see.
Yes. So, good evening, everyone. I am Dr. Kanchan Satpute. I am a senior resident at RP Center. And first, I would like to thanks to my mentor and guide, Dr. Tanuj Dada, Dr. Namrata Sharma ma'am, AIOS and APGS. So after that, I am going to start this presentation. So my topic of presentation is complications of goniotomy in primary congenital glaucoma. Lights are not on. Excuse me. So I just want to give the brief introduction before I am going to start the actual procedure and the complication. So glaucoma in children is a treatable cause of blindness if diagnosed and treated in time. So the definitive management of primary congenital glaucoma is always surgical. So procedures generally we use are goniotomy, trabeculotomy, or combined trabeculotomy with trabeculectomy. So over the years, it has been widely debated which primary surgical method is to be performed for the patients of PCG. Now, goniotomy always scores over the other surgical procedures because it is minimally invasive surgery and without the need for conjunctival dissection and no long-term risk of bleb-related complication. Now, with conventional angle surgery, we could achieve the opening of only 1/3 or 1/2 of the angle. So what we are now doing is a 360-degree goniotomy. So why 360-degree goniotomy is important? Because it opened the entire angle in a single session. And nowadays, angle surgery is considered in terms of 360-degree. So we have also the published report. So this is one RP Center study, which was done with 360-degree trabeculotomy with microcatheter, and results are very good. And they concluded that this 360-degree trabeculotomy is better as compared to the trabeculotomy at the 1 year follow-up. But microcatheter is costly, so we tried this 360-degree goniotomy, which is done with either 20-gauge MVR or we can use the needle, 24-gauge needle. So how this surgical technique is performed is the circumferential goniotomy, which is done first with the nasal goniotomy, and then we do the temporal goniotomy. So surgeon's position is shifted from nasal to temporal, in which we are doing small maneuvering of tilting of microscope and patient's head. So this gives a better visualization of angle. So now we'll see the video how this goniotomy is achieved. Am I audible? Am I audible?
Yes, yes.
Okay. So this is now we are seeing this nasal goniotomy is being performed, in which after making the side port and the with the use of this MVR blade, the goniotomy is done just above the insertion of iris. Now similarly, this temporal goniotomy is going to perform. So in this, we have just changed the position from nasal to temporal. And now we are doing the similar goniotomy, which will be till the another end of nasal goniotomy is achieved. So in this way, we can perform whole 360-degree goniotomy with some maneuvering of this lens and the microscope. And The benefit is there is no need of repeated GA if second goniotomy is required. So apart from this advantage, some complications are there which we noticed during goniotomy of our patient. So what we saw that there was no side-threatening complication till date. So most common complication we noticed was the hypema. So this hypema was also not that severe. Most of the cases it got resolved in 2 days, or sometimes it was there for 3-4 days, but it resolved its own. We have not done any hypema drainage for goniotomy. The another complication was iris in side port, iris in goniotomy cleft, and scleral perforation. So we'll see all these complications one by one. So this was the first complication as I described, and this is the most common. Many times there can be minimal or no hypema, or sometimes there can be profuse hypema, but after the irrigation aspiration and putting of the air bubble only take care of this hypema. So this is another complication which we saw during the examination under anesthesia. So in all patients of goniotomy, we generally do the EUA at 1 month, and at 1 month EUA we saw this iris was stuck in the side port. So what we did, we gently removed this stuck iris from the side port, and again after injection of viscoelastic material, we performed the goniotomy. So here one take-home message is we have to do this side port little towards the corneal side so that iris will not stuck in the side port. So this was another complication. This was another complication which again we saw during the EUA, in which after goniotomy, after performance of goniotomy, what we saw, the whole of the goniotomy cleft was covered with this iris. So iris again goes and stuck into this goniotomy cleft. So as it was only 4 weeks back, which was done, the excessive fibrosis was not there. So we just injected the viscoelastic material, and with the cannula of this viscoelastic material, iris was gently pulled away or retracted away from this goniotomy cleft. And you can see the beautifully this goniotomy cleft was opened again. The patient was fine. The IOP was borderline. So we then planned for trabeculectomy in later date because the glaucoma was advanced glaucoma. So this complication actually we noticed when pilocarpine was not available. So another take-home message here is after the goniotomy, the injection of pilocarpine is very important because it will take care of this angle open. It keeps the angle open by pulling the iris away, and there will be no such complication. Then another complication was this scleral perforation. So this is a very rare, and we saw only in one patient. So what was we noticed was during goniotomy, so this was a small child. It was a neonatal glaucoma. It was only 2 or 3 months old child, and the goniotomy was performed routinely. There was same instrument, and all the steps were same. But what we noticed after removal of this lens, there was iris prolapse. So actually there was scleral perforation, full thickness, which we sutured with the vicryl, and the iris was gently pushed inside the AC, and the wound closed nicely with the vicryl, and the patient was then later planned for trabeculectomy. So all these are the complications we noticed during our goniotomy. But apart from that, goniotomy is a minimally invasive and very effective surgery. We also got the ethical clearance for our study, and we have done almost 40 patients of 360-degree goniotomy now. We will publish our data soon. So my conclusion is, with this 360-degree goniotomy, we can get the benefit of maximum possible IOP reduction in a single procedure. So many times if we are doing partial goniotomy and again pressure is borderline, so it's very difficult to decide whether to go for another 180-degree goniotomy or simply go for trabeculectomy. So this in this way, this is important, and IOP reduction and the results are really impressive. And thank you, my RPC team. Thank you again, Tanuj sir, Namrata ma'am, and Chief. Thank you so much for the opportunity.